Okay, next we're going to have a talk from Sean Tucker at Vaxart. Sean and I overlapped for a brief period of time when we competed, both with an interest in using adenoviral vector vaccines and oral or nasal delivery to induce mucosal responses. So Sean is the Chief Scientific Officer of Vaxart, and the title of his presentation is Clinical Updates in the Development of an Oral COVID-19 Vaccine Candidate.
Great, with my invisible slides, I will start. While we're waiting for my slides, I just want to start off. Oh, wait, there I am. So, again, thank you so much for inviting me to speak today, and I'm really excited. Actually, this is the first time I've actually spoken live for since 2019, and it's great to be here without my pajamas on and giving the presentation. So, I really appreciate you paying attention. Next slide. I can do this. Okay, good. All right, since we're a public company, this is a scientific presentation, just keep that in mind. There's our forward-looking statement. With that, let me tell you about what we're doing. The nice thing is Ted gave a great example of, before about, the importance of basically trying to get something to the end user that they actually want to use. And we tried to do something as absolutely simple as possible. We thought the easiest technology to actually provide for any vaccine would be a tablet. And so this is what our vaccine looks like. It's as simple as you could possibly get it to the end user. And what we found is that if we make these enterically coated tablets, they can last a really long time, years at room temperature, we believe, and potentially use, and even tolerate some excursions above 36, 45 degrees for a few weeks. So we think these tablets are really good from the standpoint of being able to provide a solution around the world. And because Ted did just a good job, I'm not going to really focus about that. I'm going to talk a little bit more about the science, about what things I think are really important about this technology. Let me tell you how it works. It's a non-replicating adenovirus. It goes into the intestine is actually where it actually targets. And what we found is that by putting this molecular adjuvant in place, we get a very antigen-specific response to your antigen of choice, and whether that's COVID, norovirus, or influenza, that's what you get. You don't get the same sort of anti-vector response that you do when you stick, a vaccine into a needle. And that's hugely advantageous from the standpoint of being able to use this technology over and over again. Obviously, one of the big issues right now is that the world is not equal in terms of, the vaccines that are available, and certainly one of the big bottlenecks is, it's cold chain and being able to get actually people to put needles in their arms. And this is definitely a limitation. And I think that a tablet vaccine is the temperature. We'd love to think that it could be shipped by, by FedEx or, even a drone by Amazon would be great. So we think this makes it a lot simpler. Obviously when you getting the vaccine made is only step one. You still have to get it transported, put into storage. It's frozen. It has to be put in insulated vans, sent out to the places, get your primary care physician or whatever else lined up, and get the vaccine. And it takes a lot of steps. Whereas if you have an oral vaccine, you make it, you put it in your carrier, and it's ready to go. And we do think that because tablets are so simple, anybody can use it. There's not really a learning manual involved. We think this is a great technology. So, earlier today we had discussions, about the fact that we felt like we were playing whack-a-mole, and I actually changed my slides a little bit, for this presentation because of the whole Omicron thing that came up. And the way I look at this is basically right now there's a new strain that shows up, everybody hits the panic button, we all start developing the vaccine, and then of course you have to make the vaccine and get it out to the people. And I would argue with the technology today with both RNA as well as adenoviruses, making vaccines is not the limitation. It's actually the time that it takes to put it into your arm. I mean, how many people can we do in this country? It was about 1 million, maybe 2 million at max a day. That's still a long time. And right now, the virus is going faster than the rate you can put it into the arm. I would argue that oral tablets, you could go as fast as you could actually make it. It doesn't have to be, you can get off this wheel. And actually, that's point one. And the other point I'd like to make, and this is something Mark brought up this earlier today, is basically making something that would be cross-reactive could be very important. And certainly, while we haven't looked at Omicron directly, we do have lots of data that suggests that our vaccines can be actually cross-reactive against not just SARS-CoV-2 coronavirus, but other coronaviruses. And while I'm a huge fan T cells, we think that T cells can be very important in protecting from death or severe illness. I'm going to argue today very strongly that IgA is actually much better from the standpoint of being cross-reactive and cross-protective. And certainly and because we're talking about a mucosal pathogen, you brought up the whole idea, lungs are important for this sort of pathogen. I'm going to argue IgA is actually going to make a big difference from the standpoint of going forward. And again, by using cross-reactive responses as well as tablets, you can get off this wheel cycle of development. And that's the whole point of the Vaxart technology today. I'm going to start and lead off with something that's actually flu-based to illustrate a point. And so a few years ago, we did this study where we basically compared our vaccine directly to the commercial quadrivalent vaccine. And again, this is in people, not in animals. This is a people study where we gave our oral tablets with placebo injection compared to the IM injection QIV with placebo tablets and double placebo. And the way this study works is we gave the vaccines blinded and then challenged 90 to 120 days later, basically gave everybody flu. And then we just counted how many people got sick, and that was or infected. And here's the data. And again, what I would like to point out is our vaccine did pretty well compared to Fluzone. We had a 39% reduction in the illness rate compared to 27. Statistically, it's the same, but it looks good, a little bit on the lower, or having a better reduction. The other thing I want to point out is that when we looked at infection rates, and here this is defined and how much flu virus shedding, and what we found is that we had a statistically 80% chance of outperforming Fluzone, the commercial vaccine, from the standpoint of shedding. And one of the key things I want to point out is that our serum antibody responses, IgG, we're neutralizing, we're about a 10th to what Fluzone, and yet, performance-wise, we're doing pretty well. So one of the things we want to know is what was important from the standpoint of correlates. And so when we started looking, and this was actually work done by Jason Asher at BARDA, they just asked the question, what was the most important correlative protection for both the Vaxart oral tablets as well as the injected flu vaccine? For the injected flu vaccine, no surprise, it's HAI. Basically, it's really important to make an antibody response that blocks the interaction between virus and cell by IgG or receptor domain. That's really critical. For us, what was important was making an antigen-specific IgA response, but it didn't necessarily have to be, as far as we could tell, neutralizing, or it just had to be binding, and that was the most important. One of the things I want to do is just get a rough estimate. What does it take to get a protection? And so we did this logistic fit model. Keep in mind, this is a rough estimate. And what we got was that about 100 B cells correlated to about a 90% protection rate. 100 B cells antigen-specific in the peripheral blood of IgA class. If you ask the same question about Fluzone, to get the same level of protection of 90% in this flu model, you need something on the order of 2100 HAI titer. So a very, very strong response. And again, the take-home point is HAI, IgG responses from the injected vaccine were very critical to block that receptor binding. Wasn't so clear for IgA. So the other thing we did recently, and this was published just recently from our friends down the road at Stanford, was looking at, in this publication, was basically looking at what are important cellular correlates of protection, or markers of protection. And one of the things they did was use essentially mass cytometry. Basically, they conjugated antibodies to heavy metals and ran it through a mass cytometer to basically ask questions. We were able to use 40 different markers. And one of the things we found that basically the correlative protection, basically whether you shed flu virus or not, is whether you had a mucosal homing receptor on those B cells or plasmablasts that were created. So again, mucosal homing seemed to be very important, and it didn't take very much of them, as I told you before, to get a high level of protection. So here's the summary of this flu results, and then I'll start talking about COVID. So both injected and oral vaccines can be protected against influenza, infection, and illness. Each vaccine had a different, most important correlate of protection. You can't say it's the only correlate, just the most important. And the injected vaccine needed a high serum HA response, basically blocking the receptor binding to be protected. The oral vaccine needed an IgA mucosal homing B cell, but it wasn't clear whether that needed to be receptor binding. And so I'm going to argue, again, that going forward, IgA responses may not have to follow the same rules that we all think are important from an IgG response. And so switching now to COVID, I'm going to tell you about our clinical work that we're doing. We have two different candidates. Right now we're enrolling a study in phase 2 where we're looking at a a candidate that expresses just the S protein. We did see that in non-human primate models that we got a much stronger antibody response with this vaccine than we did with the S plus N, which is the candidate we took forward back during the beginning of the pandemic. We're going to go through the data, but basically the take-home point is we make good T cells and we make mucosal IgA, and these seem to be pretty strong. And again, this is a tablet vaccine, to be clear. In terms of looking at the solicited adverse events, there were really nothing to be concerned about. It was mild, transient, no significant, there's obviously no injection site pain, but really this is a very benign profile when it comes to a vaccine. When we started looking at the T cell responses, and again, we think T cells are very important, what we saw is that we got very, very strong gamma interferon responsiveness, and particularly in the CD8 compartment, where we're getting above 1% of the T cells basically are reactive to the S proteins, and they seem to be very polyfunctional in nature. We're making interferon, gamma, 10NF, CD108. So basically it looks like a really strong response. If we try to look at the same sort of responses again against all these divergent, I would say, alpha coronaviruses, beta coronaviruses, we saw a very, very strong response as well against some things like 229E. So again, the T cells that we're making seem to be cross-reactive and very strong. And so one of the things we wanted to do in this next set of studies was basically ask the question, well, our data looks like it's better than what we see in the vaccines that so let's do a study that's as head-to-head as we possibly could. So we took volunteers in Northern California to take Pfizer or Moderna, compared it to our vaccines that were tested in Southern California, and then did exactly the same time PBMCs and looked at the gamma interferon responses, TNF, CO107A, and we seem to actually produce a much stronger gamma interferon TNF response than the mRNA vaccines. So this vaccine seems to be very potent from the standpoint of T cells and very cross-reactive. As I mentioned before, and we're going to talk about how the flu study relates, we thought in flu that IgA B cells were homing to the mucosa were very potent and didn't take venom. So now let's go look to see what happens in the study. When we did this, we found that there was a dose response and that we got strong upregulation of IgA and mucosal homing plasmablasts at day 8 in the COVID study. When we pulled nasal swabs and just asked the question, are there antibodies against COVID-2? And what we found is that, yeah, a substantial number of people got actually a COVID response in the nose against SARS, S, or N, RBV. So we put the N protein in this first candidate. What we also found is that the same people having an increase in the S responses also had, for SARS-CoV-2, also had S responses against MERS, NL63, OCT43, and it didn't matter what the pre-existing history was, it really just mattered if you responded to one, you responded to all. And so it says that this vaccine is basically making a cross-reactive IgA response. When we looked at neutralizing antibody responses, we could see that there was actually some neutralizing in the nasal swabs. And actually, we didn't have many subjects, but we saw that at least a lot of the subjects were doing better than the convalescent. So we thought, hey, this vaccine seems to be doing what we want in a lot of ways. I'm going to switch gears now and talk a little bit more about a different concept. And the concept is basically one of transmission. And this was an example from that was published out of RO, the R0 2, and that's what is described now with Omicron, is that one person infects two, infects two more, infects two more. It's actually there's a lot of community transmission of Omicron, even among people that are potentially vaccinated. And certainly one of the things that's been seen with the vaccines, and this is a study that was published by Ying et al., is that the vaccines definitely have a lot of people that are infected, and you can see there's definitely a difference between the unvaccinated in red versus the vaccinated in green, but people shed virus and they can transmit it. And they can transmit it to people that actually have vaccine or people that basically aren't vaccinated, like our small kids, that didn't get the vaccine yet. So it's really a question for us, and one of the things that we were very interested in asking the question is, if I produce a mucosal response, can we block transmission? Because it's been seen before that mucosal immunity could be very important and better than injected because you're putting antibodies in the nose. Well, the next question, we want to push it a little bit further. Can we basically test this vaccine in a way to say whether I can inhibit from transmitting to somebody else that hasn't gotten the vaccine? And the way we actually tried to address that question is by doing a study in hamsters, which was to look at transmission. And again, I'm talking about transmission from a vaccinated person to a non-vaccinated person. And so what we did is we took hamsters, index animals, which were given a vaccine, either injected protein or our vaccine orally, and then infected with a very high dose to create vaccine breakthrough. Then they're put in this chamber, we blow air through to the naive animals. We put the ratios 1 index per 4, despite what it looks on the figure, and basically ask the question, how sick do the animals get and do they get infected? Pretty simple. Again, what we're trying to show is that we can block transmission not just from the person who gets vaccinated, but the person next to you that may not be vaccinated. So we look at the data, and guess what? The study actually worked pretty well. We found that, in these animals that were naive, that were exposed to the oral vaccinated animals that were infected with vaccine breakthrough, there was substantial increase or decrease in the amount of RNA you detect in the animals that were naive, and the actual clinical symptoms were much better. There was a lot less lung weight gain in those animals. So in this situation, what we're showing is basically this vaccine not only protects potentially the user, but provides some benefit to the person next to you. It's a non-self-increasing or helpful vaccine. Is that an altruistic vaccine? I don't know. But anyhow, it was a very interesting study to say the least, and it was published just a few minutes or a little while ago. With that, I'm going to switch gears. Again, one of the things I want to mention is we are starting a phase 2 trial that's enrolling right now. Part A is in the US, where we're vaccinating people that have gotten either an mRNA vaccine or naive or neophobic or something. And basically that's going on now, 96 subjects. It'll be out sometime next year. And then part B, what we'll do is a study where we look at both people that are, naive people and using the best vaccine dose in part B, and then ask the question about efficacy. Does this vaccine protect against infection or symptomatic infection? And again, this is what we're working on right now. We think this candidate is a little bit better on the antibody side of things than our prior candidate. With that, let me just give you a summary. Obviously, we believe tablets are great from the standpoint of distribution, but I also want to point out that there's some really potent things about this approach. We're broadening the response. We're creating highly immunogenic T cell side of things, as well as the antibodies. And we're seeing very high degrees of cross-reactivity to not just other SARS-CoV-2, but variants, but also to things that are beta and alpha coronaviruses. We know that from the flu study work, we thought that the most important thing was basically mucosal homing from the standpoint of a different respiratory pathogen. We're going to make that argument again and test it, whether that's true for this candidate as well. And as I mentioned before, we're currently evaluating this in a phase 2 with immunogenicity endpoints in phase 1, or part A, and efficacy endpoints in part B. And lastly, I want to talk again about the whole transmission study that we were able to do, is basically to look to see, can the vaccine not only protect the user, but can you protect the person next to you potentially by blocking infectious virus from being transmitted in an aerosolized manner. And with that, just like to thank all the people. This is just a subset of the people, but certainly a lot of people that contributed to the work that I presented today. Thank you very much.
I think we have some questions. Mucosal immunology question.
So I think it's really important to protect against what we call nose COVID, right? The localized lack of antibody responses. So IgAs are critical there. But the issue is they're short-lived and they only last about 30 days. So have you looked at IgA responses beyond that?
I don't think that the nasal IgA responses are actually short-lived. You might be right about the intestinal IgA that can be short-lived, but I think the data that I've seen from, for example, I'll just give you an example. We're testing against some of these entire coronaviruses, and certainly there's a lot of people that basically have really high antibody titers to start with. So I don't think that necessarily the nasal IgA responses are as transient as you might be. It's complicated. All I can say is we're in the middle of looking at longer term to see what happens from the vaccine standpoint. I can't tell you that much about what happens in natural infection either, other than I know that people that have been exposed to coronaviruses seem to have some pretty decent titers over time.
Is that a function of measuring cells versus cellular antibody? You're measuring cells producing antibody.
Well, in the COVID study now, what we're doing is we're taking swabs and looking at time points, post-immunization. We haven't actually analyzed the data, 360 to 180 yet, because it's still early, but we will do that. In terms of the cells, obviously, when you can only get the mucosal-only B cells 7 days post-immunization, because then they're off the mucosa, and it's a little more difficult to pull them out of people. So, but yeah, we plan on doing a lot of studies looking at the IgA responses over time.
One more question?
Fascinating talk. I'm Micah Averts from Evonik Healthcare. Two-part question. One is how do you manufacture this? I'm just curious.
I'm sorry.
How do you manufacture?
Oh yeah, so our manufacturing process is very similar to how other adenovirus is made. You take big tanks, you throw your virus in, you expand it out, and then the next step is you do a purification by using a column. So then what happens is the injected vaccines like AstraZeneca and Janssen, they go to sterile fill finish, which is cumbersome, but it can be done, obviously. What we do is we send it off to be dry, essentially lyophilized, and then once it's lyophilized, we mix it in with tablet excipients. We crunch it into tablets in these machines that make them, thousands per minute or whatever, and then we put enteric coatings on it, and then, you can blister pack it if it can last longer. So, but it's similar for our vaccine compared to all the other adenovirus until instead of doing sterile fill finish, we do drying and tableting.
Mm-hmm. And just to follow up, I don't know if you're familiar with Evonik makes enteric coatings, and we now have a couple that can release in different parts along the GI tract. Do you think there will be a difference depending on where it's released or what the immune response will be?
So the short answer is we did a study that's published in scientific reports where we basically tested the ability of the different parts of the intestine to be reactive for the vaccine, and we found that the lower small intestine was better, and that's been published. So we put the enteric coatings on to basically dry that to that area.
Perfect, thank you.
No problem.
Thank you. All right, so the next talk is going to be